Good evening, everyone. Welcome to the Commonwealth Club. I'm Mark Zitter, chair of the Zedema Project, a member of the club's Board of Governors, and your moderator for tonight. The program you are attending is called The Great Debate, Single-Payer Healthcare in California. As I'm sure most of you are aware, many Americans are fed up with what they see as a dysfunctional healthcare system and also fed up with politicians' attempts to fix it. As a result, many Californians have called for a state-based solution. A bill, the Senate Bill 562, which passed in the state Senate last year, puts on the table a government-run health plan for all California residents. The bill is called the Healthy California Act, and it would provide universal, comprehensive, single-payer health care coverage and a health care cost control system intended to benefit all residents of the state. Now, California will have a new governor this year, and the leading candidates, as well as advocates, clinicians, and other voters, are split on this issue about single payer. Everybody seems to want access for everybody to quality health care at a lower cost, but the question is single payer, or what some people think of as Medicare for all, is that the answer? I think we have a few partisans here tonight, which is just fine. Well, there are many supporters of a single-payer plan, and they point out that nearly every other industrialized country has some form of a single-payer system and is able to cover pretty much all of its citizens at lower cost than the United States. Skeptics about single-payer say that it would be too expensive and it would also be very disruptive, as several U.S. states have found. So, sounds like the makings of a great debate. Tonight we'll debate single-payer healthcare with two experts who hold differing views. And let me introduce them to you right now. On my immediate left, to your right, is Dr. Paul Song. He is co-chair of the group behind SB 562. That's the bill I mentioned. He's a board-certified radiation oncologist. He's a biotech executive, chief medical officer of ATGen Global, and a healthcare reform activist. He's a national board member of Physicians for a National Health Program and also serves as co-chair for the Campaign for a Healthy California. We also have Dr. Michael Weinberg, who is president of the Bay Area Council Economic Institute, the leading think tank focused on critical economic and policy issues facing the Silicon Valley and San Francisco region. Before joining the council, he was senior research fellow at the New America Foundation. He holds a doctoral degree in political science from the University of North Carolina. Please help me welcome Dr. Paul Song and Dr. Michael Weinberg. Now, just right up front, I want to make a prefatory comment and make a very important distinction that seems to be a confusing issue for many people in this area. That is the distinction between single-payer healthcare and universal coverage. Sounds simple, but single-payer means one payer, usually the government, and usually it's either the state government or a federal government or a provincial government, but just one government, not multiple government entities, is the only payer for healthcare. Universal coverage, of course, means that pretty much everybody gets covered. They're not the same thing, and polls show that most Americans are in favor of everybody getting covered. They agree on that. Polls also show that Americans disagree a great deal about whether the government should be the only payer. And we'll find the same thing with our experts tonight, both of whom agree strongly that pretty much everybody should be covered, but they disagree about whether the government should be the sole payer. So if you came here looking for a good fight over whether health care is a right, you're not going to get that. What you're going to get is, if we all pretty much think that everybody should be covered, what is the best way to do that? Now, you won't be surprised to hear that Dr. Song is in favor of a single-payer approach. So I want to start out by asking, Paul, why do you think single-payer is the best way to go?
So as somebody who's practiced in this system for 20 years, I've had a chance to practice at government-run hospitals like Walter Reed, private hospitals like Cedars-Sinai, and in private practice. And I will tell you that our system is very inefficient. You have people, many of you here, whose insurance coverage changes year to year. Maybe one year it's United Healthcare, next year it's Aetna, maybe the next year you're Medicare eligible. So when you go to a hospital and you get admitted, the first thing is a hospital administrator's got to figure out who is your coverage, what type of coverage do you have, a PPO, HMO, what is your copay, what's your deductible, am I in your network or not? Same thing with physicians, and that sort of inefficiency is translated to where universities like Duke University Medical Center now has more hospital administrators than hospital beds. And ultimately, that starts to consume more and more of the hospital budget. Some people estimate that it consumes 25 to 30% of the actual hospital budget each year. Same thing with physicians' offices. We're spending, $83,000 per doctor to basically hire someone to handle pre-authorizations and to fight denials, coupled with the 20 hours. So when you take that administrative waste, that's actually money that's being taken out of the healthcare system that would better be used to take care of patients or to be able to reduce costs. And when you have a single-payer system, it doesn't matter. If you change jobs, if you change insurance, you go from one hospital, one doctor, another, it's simple. They don't have to figure out who's covering your expensive. The other thing I will say, if we were really serious about reducing costs, when Kaiser uses its market share to negotiate drug prices discounts, that's considered to be good free market, good business savvy. But Medicare is forbidden to do that. If we put all the people in the state of California, pooled them together, and really used our market share to extract good concessions, bulk purchasing, that's another way we could reduce costs. So when you look at all of those things, coupled with the fact that all of the administrative waste, money that's wasted on that, Peter Lee from Covered California was bragging how they spent $150 million for marketing to enroll people in Covered California. We wouldn't have to spend money on marketing anymore. You wouldn't have to run billboards at the baseball field saying, Anthem, the official partner of the San Francisco Giants, or things along those lines. That's money that should be used to take care of patients, to expand benefits, and that's what I believe a single-payer system would do.
Right. That sounds pretty convincing. Micah, how could you possibly be opposed to that?
Well, what's interesting is that I'm not opposed to almost anything he said whatsoever. And to sort of level set of what I think makes a lot of sense. It's been an interesting week for me. Last night I was on Laura Ingraham's show on Fox News, getting yelled at. Because I support extending Medi-Cal to undocumented immigrants, and the organization that I work for supports that. I get a sense, I don't know, but it seemed like from the clapping, like maybe, this audience is gonna be much nicer than she was. She's psycho. But I get the sense that, I might be in a little bit of a, underdog position here as well. But in any case, all I'm saying is that I agree about the crazy administrative waste in our U.S. healthcare system. We don't have a market-based healthcare system. We have 10 healthcare systems, right? We have Medicare, we have Medicaid, we have employer-sponsored insurance, we have individual insurance, we have TRICARE, we have the VA, and it's really that creates the administrative chaos and expense associated with this. All I'm saying is that when we look at which international system we should move towards, I believe that we should move more towards a system like the Bismarck systems, is kind of what they're referred to as, but in Germany, Switzerland, and the Netherlands, which have a single market, which everyone is in. You can kind of think about it as like exchanges for everyone. The health insurers that participate are regulated very differently. For the most part, they're entirely nonprofit, but they're private. And we'll get into, over the course of this conversation, why I might prefer one or the other, but I just wanted to sort of level set in terms of what I prefer.
Okay, great. Before we get too far, since this is titled Single Payer Healthcare in California, and there's a bill that's in the offing, or at least the bill was passed in the state Senate in June of 2017, but later that month, Assembly Speaker Anthony Rendon shelved it. And it's been shelved ever since, I believe. Paul, what is the current status of that bill?
As you mentioned, it is shelved. I will say one thing about SB 562. As it passed in the Senate, it did not have some of the specifics that, with the intent that they would be addressed with a good faith effort by the House. It has been languishing and it's been on hold, and that's where we are right now. One thing about SB 562, before we get into specifics, because there are some areas that I think Michael will have some valid points on, is that the bill was never the whole premise of 562 is it would never be implemented into law unless every I was dotted and T was crossed, that everything, all the concerns, all the funding mechanisms, everything was in place. Once that was in place, then it would be placed into law. So that's really, it wouldn't have been implemented irresponsibly with all these loose ends to it.
Okay. So the biggest loose ends, and this comes up in the gubernatorial discussions, is how it's going to get paid for, right? So when Speaker Rendon shelved it, the bill, he called it woefully incomplete in describing how it would be paid for. Here's just a couple of quick numbers. I promise I won't let your eyes glaze over too much. But California's legislative analysts estimated that single-payer health care would cost about $400 billion. Now, this is in a state whose budget is less than $200 billion. However, did you ever hear what Mark Twain said when he was asked what he thought of Wagner's music? He said, it's not as bad as it sounds. So in some ways, it's not as bad as it sounds. It sounds like an impossible number, $400 billion, the budget's less than $200. However, California already gets $225 billion from the federal government for Medicare, Medicaid, and so forth. And presumably all that would be folded into that $400 billion. So now you're only down to $175 billion. Now, one way that could be funded, the bill did not suggest how to fund it, but the legislative analysts gave an example. It could be funded, they estimated, by a payroll tax, basically, on employers of about 15% of earned income. And even that's not as bad as it sounds. 15% more taxes sounds bad, but of course, remember, employers and employees for most companies are already paying for health care. So they'd no longer pay for health care. That would go to the tax into the fund. So it would be somewhat less than that. And some others have suggested that we should increase the sales tax, a tax on gross business receipts rather than on payroll. Any of those things could happen. But basically, I guess I'd like to ask you, Paul, how would you imagine single-payer healthcare being funded? There will have to be some kind of increase in taxes. Do you believe Californians have an appetite for more taxes?
So I will say, first and foremost, the $400 billion, I think, even if you, there are other estimates, but let's take the $400 billion. I think it's high. It's not as if this isn't what the state of California is already paying. The state of California, even the most conservative estimates estimate that we're spending $368 billion on healthcare alone right now, of which a UCLA study found that 71 cents of every healthcare dollar that's spent in California is actually paid for by us, the taxpayers, whether it be providing healthcare to every state, city employee, teachers, tax breaks to Apple and Google to provide healthcare for their employees. That 71 cents of every healthcare dollar is already being paid for us. You take that with the fact that the health insurance industry probably takes anywhere from 20 to 30 cents of every healthcare dollar away from actual patient care for administrative costs, marketing, CEO salaries, all of the above. The money is basically there. Now, in terms of how to come about it in raising taxes, there was a study that was done by the group at University of Massachusetts that looked at all sorts of potential sales tax. I think what I would say is this. That was a sort of a benchmark, or at least something to show that the people behind the bill were serious about trying to advance this, with the idea that the people that we elected to do the job would put some of their brightest minds together to find a way to make this happen if this was going to happen. Companies are being crippled by healthcare costs right now. Charlie Munger has said he calls our healthcare system the tapeworm of American competitiveness. Prior to the bailout, General Motors spent more on healthcare than it did on steel to build cars. So the idea that somehow corporations are not being crippled, and then on top of that, workers are being asked to contribute more of their paycheck towards their employer-sponsored plan. It's in the last 10 years, it's gone up 100%. In terms of what employers are being taken out of their paycheck towards their healthcare costs, and then on the back end in terms of what they pay for copays and deductibles. The other thing that, when Mike was talking about undocumented brothers and sisters, people who are using our hospitals and, quote, the hospitals are paying for uncompensated care, they're passing that on to us in terms of higher premiums. So everywhere around, we're being asked to pay. We're just not paying it, quote, in a tax, and we're not getting any credit for it. So I think when we look at the funding, it's not like we're going from 0 to 400 billion. We're, as a state, already spending 368 billion. What the analysis also showed that when you institute all of the advantages of bulk purchasing, discounts, and also reducing the administrative waste, that you actually save $30 billion a year. Now, as far as the funding, that's where I would love to use bright minds like Micah to come up with the ways to make this happen. But our legislature, in the end, was too beholden to the private insurance industry to even bother to advance this.
Yeah, okay. So, again, I agree with 90% of what he's saying. I actually think the German system is the better solution to those things. But the legislature was beholden to not doing a terrible job of legislating. This isn't just a couple of dudes sitting around talking about what should happen. If you're going to even start debating something in a healthcare committee of the California state legislature and you're going to pass it out of that august body, you should have some plan for how you come up with that additional 150 billion. Let's not even do the 400. Let's say it's only 150 billion additional dollars, right? They didn't have that plan before they passed it out of the California State Senate. That is legislative malpractice. And I think that it does a disservice. Like, I think it's fine to like a Canadian system. Like, last night, I thought the person, Laura was evil. She thought I was a lunatic. I actually think Paul's great. I don't think there's anything wrong with preferring a Canadian-style system. I happen to have another preference. However, I don't think it's great to pass an additional $150 billion implication of taxes out of the California State Senate and just say, hey, we're going to work it out later, right? So that, I really think that ought to have been taken much more seriously, much more earlier on. And actually it was. The bill that we debated in 2008, it's not like this is our first bite at the apple. Sheila Kuehl's bill in 2008 actually had a financing mechanism. At the very least, we could have started there, but we've gotten into the kind of where we are in America today, which is like a bunch of poorly specified nonsense which allows us to yell at each other. And I'm a policy wonk.
Yeah. Okay.
So can I just say one thing about the malfeasance on, if we're going to use that standard, then I would like to hear him really condemn the bullet train, because that's something that has been passed that is billions of dollars over budget. It's highly dependent on federal funding. They're not even sure where they're going to get the money to extend the rail, and yet you have an assembly and a governor and a Senate that went all in. They've passed multiple bills that didn't have funding mechanisms, so the hypocrisy is not missed when it comes to 562. The second part I will just say about Sheila Kuehl, or cap and trade. You had a bill that died in the assembly, but what happened? You had the political will of a governor who wanted to see something through. You had the assembly and the Senate, and what did they do? They did a gut and amend. They got rid of the first bill and they put in a new bill that passed. If our, quote, as people in the assembly who say they're for single payer in principle were really serious about it, they could have said, you know what, 562, it's lacking. Let's put in Sheila Kuehl's bill, update it for things that are germane 10 years later versus when her bill passed. But that's really the end. It's a lack of political will, because if you look at everything else, that's what's lacking. What's woefully incomplete is the political will, not the specifics of 562.
So, this is sort of, I'll concede the point that the California legislature has done other stupid things.
Wow.
Point
You're going
conceded.
out on a limb there. Yeah. Okay, but I really want to not just focus on whether 562 was well done or not, because the fact is the single payer issue is in play, right? And I want to distinguish something else, and that is, if single payer saves money, doesn't save money, whatever else, you're still switching. You're still asking people to pay a lot more in taxes, even if they get more benefits, even if they're getting higher wages as a result. There's a difference there. So I want to distinguish that single payer would require more taxes. But I think there's a very other interesting point, which is quite debatable. I don't mean it's wrong, but it's quite debatable. And that is, some people think single payer will save money, and some people think single payer will cost more money. And there's arguments for both. So Paul clearly feels it will save money. I heard certainly administrative simplification, less paperwork and so forth too, and the government negotiating lower prices. Micah, do you think single payer would be less expensive than our current system?
No, I don't. I don't think that. First off, it's very difficult to do single payer within an individual state. And so you get all sorts of things like, well, you want to drive a super hard bargain with the doctors in the state. Well, they can go to other states, right? So it's very different to be doing this on a federal level than doing it on the state level. But one of the things that we need to be honest about is more healthcare for more people costs more money. Maybe we like that. I like that, right? But it is something that we need to, this is just, the economic analyst in me. We need to understand that there are trade-offs. And one of the trade-offs is that more healthcare for more people costs more money. And I think that's something that it's really important to be very honest about. If we were serious about controlling healthcare costs, it's actually not primarily healthcare where we would want to be spending our money. And I'm afraid we're going to agree again. Because when you look at these other international systems and you see the better outcomes that they get in terms of mortality and all sorts of other public health issues, it turns out they don't spend vastly less than us when you put together both health spending and social services spending. It's that they spend a bunch more on social services, which it turns out has a much bigger impact on people's total health. So I think kind of the debate about single payer or not single payer is almost missing the point of what is really going to produce health. And if we're pouring more money into the healthcare system, then we're not necessarily spending the money exactly where it should be spent to produce health. Hey, some claps.
Got some applause there. By the way, I've gotten some wonderful questions. I can promise you I won't be able to ask them all, but we will definitely get to some of them. I think I want to push a little further on whether single payer would save money, because one of the key arguments, and it's a reasonable argument, it's just not completely obvious to me, is that the government, if it really had full control of all the levers, could negotiate prices down or could just set prices lower. And if you look at our healthcare system, there's examples where that's happened. And there's the examples where government, which is us, ultimately, doesn't have the gumption to do it. So I want to ask you, do you think if the government had their hand on all the price levers, not just the VA here for 10 million people or something like that, and the government had to make choices saying, we're going to close these hospitals, or we're going to pay doctors not a little bit less, but a lot less if we're going to save money, or the government says, we're going to pick these 2 drugs out of 5 in the category, and those are the only ones we're going to cover, do you think that our federal government would be able, or our state government in this case, would be able to make those hard decisions and stick with them?
So I would say that what's really suggestive of that is in the run-up to the Affordable Care Act, there were 3,300 registered healthcare lobbyists for the 535 members of Congress. They spent more than $1.2 million a day, and in total more than what was spent on the Bush-Kerry election. And that's why the Affordable Care Act has no insurance rate regulation and no pharmaceutical drug pricing controls. So if you give the power to, quote, the federal government to do this, who's beholden to the private insurance industry and the pharmaceutical industry, the answer is no. And I will say this, with regard to reducing formularies or denying care or death panels, we have that right now, and it's the private insurance industry. They constantly get between me and my patients day after day telling me what drug I can prescribe, what procedures I can do. So when they think that the government will do that, no. But the problem is this, when United Healthcare, when Kaiser, they negotiate bulk purchases, whether it's saline, whether it be pharmaceuticals, they don't pass those savings on to keep premiums down for their enrollees. That's what a single payer system would ultimately do. And as far as from a physician's office, sure, maybe I'll get paid less under a single payer health plan. Frankly, I get paid less for Medicare, treating Medicare patients than I do United Healthcare. But I'm not spending all this money fighting with the insurance company to get paid for things that I should get paid for, nor am I fighting to get pre-authorization. So the amount of money that I waste hiring people to fight an unnecessary battle to practice medicine the way I've been trained is greatly offsets whatever, quote, more money that they will pay a physician. So I think a simplified system would free up my office to allow me to spend more time with patients and less time fighting with insurance companies.
Yeah. Well, there'd certainly be less paperwork there. Michael, what do you think about that?
Yeah, I totally agree that a simple system would make a lot more sense. But I think that our simple system should include private insurers. Mm-hmm. So if you looked at the sort of March Madness style tournament that a number of eminent economists from across the political spectrum did in the New York Times at the end of last year, and it evaluated these various different systems on objective measures of access, quality, and cost. Canada was knocked out in the first round. One of the things that's sort of poorly understood is that the Canadian system, which is the system that 562 is modeled on, is actually one of the worst performing health systems in the entire world by all objective analyses. So, you know, that's just a weird thing to choose as your thing to emulate. Whereas the ultimate winner of this bracket was Switzerland in a narrow battle over France. Both Switzerland and France have private insurers, and they use them in different ways. But the thing that is important to understand is that, this is a single system that people are in. They're not in 10 different systems, including the United States' is multiple single-payer systems. But one last thing that it's also super important to understand. When we talk about Medicare for All, there's a very important benefit that the Medicare program does not cover. And that's the long-term care benefit. And we have a tremendous amount of long-term care needs here in the United States, which are paid for now through another single-payer system that we have called Medicaid. So we have a long-term care insurance program, but the deductible is your life savings. If we change to a system in which everyone has universal, unlimited, free access to long-term care, that is an enormously expensive proposition. And we just need to understand there are trade-offs associated with this if we're talking about what the real costs of these systems are.
So I will say one thing with regard to Canada. It would not be the premier model of single payer that I would hold up. My parents immigrated from Korea. Korea has a single payer system that's actually considered one of the best systems in the world. Taiwan has a system as well. I would say with regard to Canada, part of the reason you're seeing, just like with the British health system, is you saw the Conservatives chronically underfunding healthcare in both of those countries and trying to privatize it. And those private solutions, just like our Medicare Advantage here, have ended up costing a lot more and delivering far less. There was a recent study from Stanford and MIT economists that basically showed that for our Medicare Advantage plans, they're paying actually less per enrollee in terms of coverage than the traditional Medicare, despite charging 20% more in terms of enrollees. Canada, everyone likes to show Canada as the reason why single payer is not great. I'm not saying that single payer is a perfect system. I'm saying, frankly, there is no perfect healthcare system, but no one has ever gone bankrupt in Canada or had to mortgage their future because they got sick. And that's what I would say is, I think, we actually agree on a lot more than disagree. But I think the most important thing I would say is this: what is the basic level of coverage that everyone should have? And then if you want to have supplemental private insurance and things of that nature, I think, fine. I'm not opposed to that, but we should have some basic coverage that maximizes the market power of 33 million people in the state of California get the best discounts possible. The other thing I will just say with regard to long-term care, my father-in-law was in palliative care. We had him in long-term care. It is devastating. We were spending, $10,000 to $12,000 a month on him, and fortunately, we had the resources to do that. But the reality is, a lot of people don't. And with regard to 562, I know that was one of the things that it was considering. But in the end, if we couldn't find a way to cover that, but we were still able to just cover basic coverage for every single person, we'd still come out way ahead of what we have now.
But just a quick question, is that what people actually think they're supporting when they support 562? Do they understand that this massive healthcare need, which is extraordinarily expensive, that's actually super important for people, is not part of what's covered by this program? This room might, but this is a very, very smart room. It's true. I mean, I'm pandering, and it's true. But I genuinely think that most people that support 562 think of it as free, unlimited health care of every type.
I will say that I think that maybe there are some people that believe that, but as they're not getting it right now, I don't think that if the final bill didn't have that, but they still had better access to care, far cheaper, less risk of going bankrupt because they got sick, and had no middleman that was denying every single step of the way, I think they'd still be happier with that type of plan.
Mm-hmm. So there's many questions here about the insurance industry. Okay, so some of them are not very flattering. Many of them say, do insurance companies go out of business under single payer, or do they still play a role? And it's been pointed out that when you looked at the rollout of healthcare.gov and the Affordable Care Act for only 10 million or so Americans, now we're talking about 3 times that just for the state of California, three plus times that. Can the government really handle the implementation of single payer?
No.
So, you say no, you're
and we like to say the government.
Yeah.
Like, remember, the government isn't the imaginary government we wish we had. It's the messy, crazy, democratic government of the United States, which is currently run by a lunatic, right? So every time you say the government should do something, you're taking your chances.
So I will say that if you just take Covered California for a minute, which has been lauded as the model exchange, there are 66,000 people today who are in Covered California that are in a single payer system, meaning they only have one choice of a provider on the plan. There are 216,000 in California today that only have 2 choices. So the idea that that for them, they already have single payer. I think if you moved everyone to one universal system, and all it is just a pool of money goes into one thing and that allocates it out, I think that's a lot easier to do than trying to herd 12 different HMOs and PPOs and Medicaid HMOs and all of these other plans together. I think that if we can't do one payer, then I think there's something wrong.
And so the insurance companies go out of business, there's no more Kaiser Permanente, or do they have any role at all?
Kaiser is an excellent accountable care organization. They give great care, but as an insurance company, I don't think they need to function as.
But and let's be clear. I mean, you folks probably did your research, like so Kaiser Permanente. Bernard Tyson is currently the chair of the Bay Area Council, which is the organization that I work for. Like, they go out of business. They are. Their ability to do what it is that they do within their system is predicated on their ability to be the payer for their own system. So that is the part, that is the model of these managed care organizations. And that's what I think, I actually think there is a value in having these accountable care organizations competing with each other and having private competition. And I think that the proof is in the pudding. Look at the ways in which these systems are rated across the world on access, on quality, and on cost. And you'll find that many of the ones that are very high quality have private insurers that are involved, albeit in a very different way. And I think that it will be easier for us within our crazy country to get to that kind of a system. We've been having kind of an abstract conversation up until this point, but actually we have to get from here to there. And if you have examples of great countries and great health systems that are a whole lot closer to our health system and something we could conceivably negotiate within a country where not everybody actually agrees with us, then that's another part of the reason why, in practical terms, I prefer the Bismarck systems rather than something like, Korea or the other systems.
I'll just say one thing about the Bismarck system, because it is quite good, but you have to realize that so it's really an employer-sponsored system where the employer pays a percentage far less than what our companies pay here, and then the employee pays based on a percentage of their payroll. The problem between our system and theirs is they have far greater utilization. I looked at what they cover. They cover things that you wouldn't even dare to try to get covered here in the United States. And patients, the denials, they don't have the denials that we have. Here in the state of California, the last 9 years, we've had over 45 million denials. And what's really insidious about this, David Ignatius wrote an article about this in the LA Times, is that if you take the time to fight with the insurance company, either you as a patient or your doctor spends hours doing this, that 50% of the time they get overturned. What does that tell you? That a lot of the insurance companies here are purposely denying it with the intent that you probably are going to get too worn out fighting it and they'll just pocket the money. And if they do decide to pay back what they should have paid at the beginning, they've sat on this for 4 or 5 months and banked the interest. So when we talk about insurance companies, I think that you have to realize they don't work for the best interest. Their interests are completely malaligned with the interest of the people that buy their product.
So they can be, but they are not always and everywhere. Like what you're talking about is interests, right? And alignment of interests. Well, that's incentives. And you can set up an incentive system, and parts of our healthcare system work this way, parts of international healthcare systems work this way, where insurers are actually held accountable for population health, and they compete with each other on the basis of providing population health, and they actually aren't compensated. And one of the big problems that a lot of people, including myself, had with 562 and have with single-payer systems generally is that they're generally based on a fee-for-service chassis. So it's about like you get this set price for this set procedure, and you deliver it at that price. And they have a lot more utilization in these other countries. They just do it at a much lower price. I actually don't think that's the right set of incentives at all. I think that, if we set up this much simpler system with a series of accountable care organizations that are competing with each other, then they can do whatever. They can put, so you know about this, right? Really, you just want people hiking around in the woods. Really, you just want people like petting ponies, like that's, and like having stable housing, right? And so you have these accountable care organizations, not fee-for-service organizations, that are actually beginning, Kaiser just made a $200 million investment in affordable housing here in the Bay Area. And let me tell you, newsflash, it wasn't entirely charitable. It actually matters for Kaiser Permanente and these other companies that there is stable, affordable housing for people in the Bay Area. That has a much bigger impact on people's health than healthcare access. But right now, it's a freaking mess. It is an absolute mess, and even the most well-meaning health insurance company is not empowered to go out of business. And there are so many different ways in which they not only have bad incentives, but they have like 15 different types of bad incentives, right? So they're trying to play some crazy game where they maximize the revenue over here in one way and do it another way. Doctors and hospitals, we're like measuring quality in 20 different ways. We do need a simpler system. We just disagree on what that simple system should be.
I will say this. I actually like accountable care organizations, although I think under the Affordable Care Act, they've kind of failed because they've still fragmented. Kaiser has done a tremendous job at integrated care. And I would like them to continue doing that. I just don't think they need to be in the insurance industry. I think we could hold that, get everyone's funds and give it back to it. Look, Kaiser is sitting on, I think last I heard, 2,000 times the necessary reserves required by an insurance company. While they've done great things like invest in affordable housing, they've also spent a lot of money investing in a VC arm for home dialysis units. They've actually laid off custodial staff because they've invested in a for-profit cleaning service. Is that stuff that an insurance company needs to be doing? This is money that they could keep premiums lower and pass it on to people who are having trouble. Since the Affordable Care Act, it should be pointed out, just from 2015 to 2017, the number of people that report having difficulty paying their monthly premiums has gone up to almost 40%. That's no positive measure. And there's no insurance rate regulation. So if all these places are making so much money, let's give some of that back to the insurers. To the people.
Mm-hmm. Okay. Well, so here's the part that I wrestle with a bit. The real problem we have with costs in healthcare is very simple. We collectively want to consume more healthcare than we collectively want to pay for. We're complaining it costs too much money. Right now, the organizations that have to try to manage that, have to say no, are the insurance companies. So they're going to be unpopular. Maybe they're doing a crappy job, maybe they're doing a great job. They're going to be unpopular. What happens if that becomes the government that has to say no? because the system is really set up so people will always want more than we can probably
So it's
afford.
interesting. A member of the assembly who will remain nameless and I were hanging out talking to a single payer advocate, and this member of the assembly was talking about, well, we actually use private insurance companies in the Medicaid program. Almost everybody is on Medicaid managed care. And that looks a lot more like these Bismarck-type systems than they're very heavily regulated, they have a particular public mission, and so on. And the reason why we are working through these private insurance companies is because the people in government realized we didn't want to be the people saying no. But we also realized somebody had to say no. So we're working with these insurance companies. Mm-hmm. And that is tough. It's tough. In a lot of other countries, these decisions are made by, and here I'm not using this as a curse word, unelected bureaucrats. I'm actually cool with unelected bureaucrats. I'm a policy wonk. But I don't know if in the United States of America, we would really turn over to a politically sort of, insulated set of experts to make this level of decisions for us in this country. I don't know if that's politically plausible.
So just for that last thought, Peter Lee, who runs Covered California, who is not elected but appointed, came out against Prop 45, which was insurance rate regulation, which would have put the right to regulate rates in an elected official, Dave Jones. He came out against it, and since he came out against it, insurance rates have continued to climb well beyond what he projected for Covered California. So there is somebody who is not an elected official who is inserting himself into the dialogue there. The other thing I would say about Medicaid, privatization of Medicaid, is one of the only doctors who've continually taken Medicaid since my 11 years in California. I will say the Medicaid HMOs have been a disaster for patients. Medicaid, which covers right now 13 million people here in the state of California, is being sued by MALDEF, the Mexican American Legal Defense Fund, for being separate and unequal because we are 47th in the nation in terms of physician reimbursement. So what happens? You can't find doctors that are willing to treat Medicaid patients, so the access to care is not there. Secondly, when they, in a testimony in Sacramento, which I have the transcripts for, they looked at the Medicaid private HMO plans. Majority of them are not spending the amount of money that they're supposed to be dictated to spend per enrollee, and the rankings of a lot of these Medicaid HMOs are horrendous. So that the privatization, all that's done is put more money in the pockets of Centene, Health Net, so that they could be bought by Centene. But that money did not translate to better care for patients under Medicaid.
No, look, like when the state was in charge of Medicaid, the state was getting sued, and the state is still getting sued for various aspects of administration of the Medicaid program. It sucks saying no, people sue you. I'm not saying that like every Medicaid HMO is amazing. I'm saying that, you're going to get sued if you say no to people. It's a matter of degrees. Ultimately, I feel like there's a continuum, and we're in a couple of places that are sort of adjacent to each other in the continuum. I think that the single payer system you're talking about would have a place for private insurers. I think you've mentioned supplemental coverage, perhaps coverage for long-term care and other things. I would place those private insurers a little bit further down the continuum, but it's not a fundamental disagreement about whether or not there should be infinite, unlimited free health care or nasty, evil private insurance companies for everyone.
I want to go back to something you said about doctors not taking Medi-Cal. It's called Medi-Cal. Medicaid is called Medi-Cal in California, of course, because the rates are too low. One of the main goals of single payer is to moderate costs. As most people know, we are most countries are 30 to 50% less expensive than the US, and California is no exception. However, healthcare is also 18% of our economy and 1 in 9 jobs, okay? So if single payer were to be really successful, it wouldn't just moderate costs. It wouldn't just knock it down 2%. It would have to knock it down a lot to get anywhere near the other countries. And one way you do that, there's only a couple of ways to do it since healthcare is so labor intensive. And one way is you either have a lot fewer doctors or you pay them a lot less. So if doctors currently don't want to take Medi-Cal rates, wouldn't single payer rates be lower still?
No, because, well, Medi-Cal is a fraction of Medicare, and most doctors do participate in Medicare. And what I said before is the average doctor, and this was from the American Medical Association 2011 study, and it's worse since then, spends 20 hours a week after seeing patients fighting with insurance companies, dealing with pre-authorization, things of that nature. That's 20 less hours they could actually spend taking care of patients. So even if you got paid less per patient, if you got to see more because the administrative hassle was less, you probably would come out ahead. Second thing is that as far as the you also have to employ staff to fight with insurance companies constantly. So that's another cost that goes away. Third thing is medical malpractice is far less in countries that have any type of universal health care system that's guaranteed to their citizens, because especially in the state of California, which put a cap on pain and suffering at $250,000, the reason medical malpractice remains high is not because for the pain and suffering, but is for the continued medical cost care for that person that has been harmed as a result of your injury, of your malpractice. If you have people constantly having access to health care for the rest of their lives, no matter what, that cost goes away, and that's why malpractice costs are actually less than other countries as well. So those three things, I think, when a doctor will take a step back and beyond the ideology, and they look at how much easier it is right now for them to deal with a Medicare recipient than it is to deal with some of these really awful insurers, and then as a result, it's going to save money. Even if they get paid less per enrollee, they will come out pretty much the same with far less headache. Right now, 50% of all physicians are burned out and they hate their profession. It's really sad. And so I think this would eliminate a lot of those headaches.
Yeah, absolutely. I mean, but there's no question. But look, talk to your doctors. Ask them if they love Medicare or love Medicaid. They don't. They don't love private insurance companies either. What is creating all of this administrative hassle is not the fact that, if only they could all have Medi-Cal, they would be in, hog heaven. It's that they have to deal with 10 or 15 different types of payers, and, their patients might be bouncing back and forth, among them. So any single system that we move towards that is more rational is going to solve that tremendously terrible issue, which we all agree on.
So that's raises some interesting issues. The political supporters and opponents of 562, interesting. There's lots of both, but I'll just name a couple of them. In support, the California Nurses Association, the California Federation of Teachers, and the State Insurance Commissioner, Dave Jones. Opposed include the California Medical Association, interesting, California Chamber of Commerce and Small Business Association, and a number of the business groups. Obviously, the California Association of Health Plans, not surprisingly. The California Hospital Association has not taken a position. They want to see more details. Okay, interesting. But interesting, Paul, why do you think the California Medical Association is opposed to 562?
Because as it stands right now, a disproportionate number of doctors in CMA also are Kaiser physicians, because unlike myself, when I have to join the CMA and pay $1,800 a year annual dues, that comes out of my own pockets, whereas Kaiser pays for each of their doctors to join CMA. They are also an insurance company and have a vested interest to preserve that. They were also very much against Prop 45, which would have regulated insurance rates. And I think a lot of doctors, again, it is changing. You have a leadership that's very much entrenched in their own ideology, but if you take a poll of CMA members, that the overall consensus is no longer anti-single payer. It is changing like the rest of our country is.
Mm-hmm. Okay. So, Michael, I'm curious as to why the business community isn't in favor of single payer, if they think that would help control costs and simplify their lives and their employees' lives.
Well, they don't think that.
Yeah.
So the business community tends to be, we love talking about disruption here, but the business community actually doesn't think that it's an awesome idea to, for example, just for starters, we may hate everybody in the insurance industry, but there are actually about 500,000 people working in the insurance industry in California currently, from health insurance companies to health insurance agents and so on. Businesses actually don't think it's an awesome idea to suddenly put 500,000 people in California out of work. They don't think it's an awesome idea to suddenly raise their payroll taxes or whatever it is by 15%. They think it's awful idea to think about doing this on a state-based level because most of these businesses are operating in multiple states. So having a completely different healthcare system in one state makes absolutely no sense whatsoever. But businesses, a lot of them, have been very supportive of health reform efforts. They tend to be more incrementalist in their thinking and say, hey, if we have these really well reviewed health systems around the world that we could get to through a more incremental, less disruptive process, that's what we should do.
Mm-hmm. Okay. You know, it's important to know what's happened in some other states, or at least to discuss. So Vermont is, most people know, the home state of Bernie Sanders, the senator who's championed a national Medicare for All plan. That's, of course, on the national level. In 2014, the governor then, Peter Shumlin, championed single-payer health care in his home state. It passed, but it was withdrawn a few years later when the real costs became clear. Okay? Now, Colorado had single-payer health care on its ballot in November of 2016. You may recall Hillary Clinton won that state by 5%, and in the same election, an astonishing 79% of Coloradans voted against single-payer health care there in that state. So there's something going on where the states, when they walk up to the cliff of single-payer health care, decide against it. So do you believe California could be successful where other states have not been, and if so, why?
So I just want to say one thing about Vermont, because it's the one that a lot of anti-single-payer people like to tout. First of all, it's only got a population of 500,000. And initially they thought maybe because it was small, that would be the ideal place to start, but that was precisely why it was very difficult. Vermont is surrounded by New York and Massachusetts. You have a lot of people who work in other states and get their coverage through an employer in the other states. The risk pool simply wasn't big enough. They couldn't get they have a fairly large military community that was on TRICARE. So by the time they carved everything out, it was a very, very, very small risk pool. And then the costs of starting that were just cost prohibitive. So that's why Vermont didn't work. Again, I think Colorado came at a time when the ACA was just in place and there were a lot of people who wanted to give it a chance. I think now that we've had the ACA in place for quite a few years and people are having difficulty more than ever with their co-pays and deductibles and premiums, I think if you were to put that to the poll, it may not pass still, but it would be a lot closer than it was back in the day. And that's where I think we're at. I think it's like marriage equality. I think that when it first started, it was something that was the majority of people didn't want to support. Maybe some people were in favor of civil unions. But with time, people started to come around to that. And that's what's happening with single payer. There was a recent study that just came out a month ago that showed for the first time a clear majority does support a single payer Medicare for all plan.
Mm-hmm. Now, the Kaiser Family Foundation had that may be the study you're referring to. The challenge was that when they explained to people that single payer also meant that if they were employed and they had employer-sponsored insurance, they would have to lose that, then it dropped fairly substantially. So I guess the question is, in California, should SB 562 or some flavor of that pass, would the average employed Californian find that their health plan was better, worse, or about the same as what they had?
Well, first of all, I think that the idea of cost, I think, as I mentioned before, if you look at the last 10 years, the amount, for those of you that get your coverage through an employer-sponsored plan, the majority of people have had to contribute 100% more over the last 10 years towards their employer-sponsored plan. So that's money that's being taken out of their paycheck, quote, a hidden tax. And then on the back end, when they got sick and utilized it, they had to pay 70% higher amount in co-pays and deductibles over the same 10-year period of time. Not to mention things that aren't covered. So I think that a lot of people will find, and that doesn't even take into account if their employer plan is one that only covers 70% of costs, right? So there are a lot of expenses. Today, actually, there was a report that came out, the Millman Index, that the average family of four out of pocket, the cost to cover that is $28,000 a year in 2018. So when you tell people this is what they're spending, but they're not getting any tax credits for it, and that by changing it to maybe a 2.5% payroll tax or 2.5% sales tax, they would gladly switch, especially if they know that they're not going to get denied all the time and they're going to have more enhanced benefits, no more co-pays, no more deductibles.
So let's be really clear about what we're talking about. We're talking about Medicaid for all, right? That's what the program. Let's look at what the program actually looks like. It looks like the Medicaid program, 562. It doesn't look like the Medicare program.
And you say that
will
because there's no
lose-
premiums and no cost sharing, correct?
Right, exactly.
Which is what
it doesn't at all. The
Medi-
Medicare program, there was no Part A, B, C, and D. It does not look like the Medicare program. If we pass Medicaid for all, which is okay, Medicaid is actually not terrible. There are winners and losers. If you don't believe that, you don't understand how life works. There are a lot. Let me start with the winners, though. Let me start with the winners. I'm not up here saying, I actually think there are a lot of people that would be better off in the state of California currently under a Medicaid for all type system, under a 562 type system. There's no question whatsoever about that. Many people who are uninsured, many people in the individual market, some people that have employer-sponsored health insurance would be unquestionably better off under 562. Many other people who have Medicare, many other people who have good employer-sponsored insurance, many other people that have what they consider to be good policies in the individual market would be worse off under 562. It's not going to be better for everyone. Life involves trade-offs, and I don't think that people are going to want to make those trade-offs when they're explained to them.
So with regard to Medicare, my mom is on Medicare, and as you know, it covers 80% of certain charges, outpatient charges. Her prescription drug prices, she's a transplant recipient, are staggering. Fortunately, she has some supplemental insurance to offset that. But last year, 45 million Americans reported foregoing filling one prescription here in the United States. 22% were seniors. I do believe that Congress has constantly undermined Medicare, and there's no bulk purchasing in Medicare. There's no prescription drug negotiating in Medicare. And so as a result, if you gave those things, the biggest cost driver for seniors right now is their prescription medication. And now all of a sudden, if you were able to do away with the 80-20 and they had 100% coverage for outpatient services, and then you gave them better drug prescription coverage, I think they would come out ahead.
Yeah.
I know my mom would come out ahead.
Cool. So let's be honest about this. We're telling seniors your Medicare goes away, but it's going to be cool. That's what we're telling them. And maybe they agree, and maybe they think it's right, and maybe for some people they will. But let's be honest that it isn't Medicare for all. It's no more Medicare for all to get Medicaid for all.
No. I will say this: that technically, it is.
Technically, it is.
Technically, because it's a state-run program, right? So Medicaid is a state-run program that is 50% funded by the federal government, 50% funded by the state, or unless you're a state like Louisiana or one of the welfare states where you get a greater federal contribution. So in the sense that if we are setting up our own state program, it is, quote, more of a Medicaid, because Medicare is still something that's more federal. But I think that in using that term, it begins to imply that it's a lesser care, because we all know that, frankly, Medicaid in the state of California stinks compared to the other coverages that we have, short of being uninsured. But it is not the Medicaid or Medi-Cal that people here currently have.
So it's the most like the thing that stinks the most, but it's going to be great.
No, that is a marketing branding problem. It is, because
you wouldn't call it. I know you don't.
You
want to
wouldn't call it
Medi-Cal.
Medicaid for all, but it is structurally more like Medicaid than Medicare, which has a different connotation. Let me bring up something else that's really important to understand, and that is currently more than half of California funding for Californians for healthcare comes from the federal government. Okay, another 16% comes from employers. Both those things are currently outside of what you think of as single payer within California. And if we were to get single payer healthcare in California, that would require, if we wanted to include the Medicare and Medicaid funds, which is essential, right? That's more than half. Got to get waivers from the Trump administration. Okay? Now remember, employers in America, this is controversial, but it's true. Employers get tax breaks for paying people healthcare, giving people healthcare rather than wages. So those are federal tax subsidies. If we wanted employers to pay into a statewide pool, also crucial for 562 to work, that would require employers diverting their federal subsidies to this state-based fund, which would require an act of Congress, including a revision of the tax code. So the question is, whether that's a good idea or not, what likelihood do we think that that's happening anytime in the near future? Politically. It's a real question. It has to.
Right.
Yeah.
So, and I think that is a legitimate argument as it stands right now with just, let's take the federal waiver. Clearly, under this administration, that would never happen. But the idea is that, and certainly under this governor, it would never happen. We don't even need to get to the president because our governor is against it. But I would say this, that in 2020, if we do have a president who is in favor of single payer or Medicare for all, it is far more likely for a state to pass it than a Congress that continues to be beholden to the private insurance industry and pharmaceutical industry. That's why you do have a congresswoman from Washington, Pramila Jayapal, who has reintroduced the McDermott waiver to try to get states to then be able to implement things. So it's not something that happens overnight. This is something that is going to take time. We have to get all the specifics ironed out to really satisfy people like Micah and others to make sure that it's there. But the federal waiver was always going to be a problem. But that was, again, you've got to tackle it step by step by step.
Mm-hmm. Okay. We have a lot of questions here that have to do with the for-profit insurance industry. And I want to make a little statement, see what you think about this. And that is that, first of all, the insurance industry is partly for-profit and partly not-for-profit. And it's not really clear that there's a tremendous difference on average about how those insurers behave, number one, for-profit or not-for-profit. So the profit motive doesn't seem to be the main thing. Not-for-profit insurers want to get revenue as well. In terms of single payer, it seems that just as Medicare, Part B, the hospital benefit, for instance, uses private insurers to administer it, right? Presumably, if we went to single payer in California, there still would be some role for insurers, and not just around the edges, but to do some of the administration piece as well. And presumably, some of those insurers would still be for-profit, I believe. Do we think that's the case? Do we think that actually matters very much? Because a lot of the questioners think it does, if we have a for-profit insurance industry existing at all.
I think the way that 562 was envisioned and written, that would not be the case, that you would have one central administrator of a big pool of money that would then serve as the distributor of that to
And those would
all
be
of the
government
providers.
employees?
Yes.
Okay, unlike the way Medicare operates.
Yes.
Okay.
And as I mentioned about Medicare Part, at least let's take all of the privatization of Medicare. The Medicare Advantage plans, as I mentioned, there was a study from Stanford MIT economists that came out in 2017 that basically showed that they charge 20% more per provider, per enrollee, and yet they spend less per enrollee. They have not shown that they can be more cost-effective than the current Medicare system.
But that's managed Medicare. Some of those managed Medicare plans are not-for-profit, and some are for-profit.
Right, and then that's the whole other thing about this, quote, not-for-profit. I think that certainly whether it be insurance companies or whether it be hospital chains that are, quote, not-for-profit, we all know that they certainly behave and act as if they're for profit.
Yeah, I mean, like,
Micah, think about overseas. Other countries use insurers sometimes. Some of them are for-profit insurers in their quote-unquote single-payer systems, in a sense, right?
I totally agree with Paul. We should get back to agreeing. We're agreeing on everything there, and they got a little dicey. It's not what you make. It's not whether you make money. It's what you make money for doing. If you have any kind of health provider, whether it's a hospital or a health insurer, that is not being compensated for keeping people as healthy as possible, then you have a bad system, whether or not it's for-profit or not-for-profit. Mm-hmm. It really comes down, again, to the incentives that these folks have. And so that's why people get worried about a single-payer system which is based on a fee-for-service mentality, because that keeps the costs in the health system high and growing, because it provides an incentive for providers to provide greater volume rather than greater value. So the type of single-payer system, even a Canadian-style single-payer system that I'd be more interested in and that'd be cool to sit down and talk about, would be one where you think about how could you really utilize, like operationally, these ACOs that were held accountable for health rather than a single payer system, which is just unlimited fee for service for everyone. I think that'd be really cool to think about.
Great. Some great thinking there. By the way, fantastic questions. I've done a lot of programs at the Commonwealth Club, but this is a personal record for the number of questions. And the quality is terrific. I feel like we should publish these in a book. And we could be here all night, but we don't have time. And unfortunately, we're at the part of the program where we have time for just one more question. And I'm going to ask the same question of both of you. And here it is. If single-payer healthcare were to become the law in California, would that make a national single-payer system more likely or less likely, or the same?
I think, again, Vermont with a population of 500,000, I'm not sure would have much impact. But with the now fifth largest economy in the world with a population of 33 million, if you could show that you could have better outcomes and greatly reduce costs, I think states would be foolish not to consider that.
Well, the question is, would the feds then say we should do it?
Again, I think the problem with the federal government, and I got in a lot of trouble for referring to elected officials, is that you have, unfortunately, a Congress that is still highly beholden to corporations and specifically the pharmaceutical industry and the insurance industry.
Mm-hmm. Yeah, so what California does matters. When I was on Laura Ingraham last night, she was like, going after California. I'm like, oh, it's terrible to be living here in the fifth largest economy in the world that's creating the most jobs in the entire country. Yes, it's a socialist hellscape. You're totally right. No, not everything's perfect here. We have, our rate of poverty is too high. We got lots of things that we got to work on, but absolutely what California does matters. So what we should do is we should do the best thing. And we can do the best thing, right? Not only operationally, and the best thing, of course, I believe, is more of a Bismarck-style system, so we can get there, right? But it's also practical. We can get there from here. So what we do matters. So let's keep thinking about this. Let's keep proposing it. Let's keep having substantive, engaged conversations like this one. I really appreciate having this conversation with you. Really appreciate the super informed audience. And thanks for letting me chat at you for a while.
Great. I'd like to thank our speakers, Dr. Paul Song, co-chair of the Campaign for a Healthy California, and Dr. Michael Weinberg, president of the Bay Area Council Economic Institute. We also thank our live audience here in San Francisco, also our audiences on the radio, television, and the internet. I'm Mark Zitter of the Zedema Project, and now this meeting of the Commonwealth Club, the place where you are in the know, is adjourned.